Welcome to Module 3 of the Sedation Anesthesia of Pediatric Patients. I'm Gary Badger, pediatric dentist at the University of Texas School of Dentistry at Houston. I receive no financial benefits that would create a conflict of interest or restrict my independent judgment with regard to the content of this presentation. At any time while viewing the video streaming course, you can take a break by simply pausing your computer. At the completion of this section, you will be asked to take a short exam in order to complete the requirements for streaming video courses. At the time, you will receive instructions regarding taking the exam. This section presents information to create an understanding of the continuum of sedation through the dentist can make appropriate choices of pharmacologic agents that can safely and effectively be used for various pediatric dental sedation procedures. This course is part of a 16-hour comprehensive program designed to meet the requirements of Texas State Board Dental Examiners Rule 110.17, Sedation Anesthesia of Pediatric Patients. Today we'll be discussing pediatric anatomical and physiologic differences. Upon completion of this course, you will be able to understand the airway anatomical differences in pediatric patients prior to sedation or anesthesia. Understand the physiological differences in airway management of children, and understand the reasons for preparing for sedation levels deeper than permitted. The patient history and evaluation is essential. It's dependent upon the differences in adult versus the child laryngeal cartilage. The funnel shape of the child patient results in a narrowing of the airway inferiorly compared to an adult. The narrowing of the airway results in the airway being more anterior and superior with the vocal cords sloping from anterior to posterior. Therefore, when sweeping the tongue from the right to the left, the vocal cords will be more oriented superiorly and anteriorly for tube insertion. If the patient has an upper airway infection and edema of the surrounding tissue, then the narrowed airway is compromised exponentially, thereby altering the ventilation. When airflow is turbulent, in addition, resistance is inversely proportional to the fifth power rather than the fourth power, therefore a tenfold increase. Therefore, patients with agitation, such as crying, have an increased airway resistance and ventilation is more difficult. Airway differences and results of inflammation are exhibited in this slide. On the upper left-hand side, the normal infant who has 4 millimeter lumen, where edema can occur, as you see in the right slide, goes from 4 millimeters to 1 millimeter and compromises severely the amount of airflow that will be available. In the adult below, the large lumen of 8 millimeters allows this person to breathe exceptionally well in the presence of inflammation. Not so with the child, because the child has a limited size based upon the development. And up until the age of 8, the lungs and the lung field and the trachea and the bronchioles are much smaller and therefore are easily compromised. Purcell's law tells us that reducing the radius of a tube by 1/2 requires an increase in pressure 16-fold to maintain the same speed of gas flow through the tube. This law applies to the exponential decrease in lumen size and the increased pressure necessary to have the same volume of air going in those tubes that are inflamed or as a result of asthma or some other infection. The pediatric airway anatomy, the differences from the adult. The upper airway is proportionally narrower. The children have small nares, large tongue, and epiglottis, enlarged tonsils and adenoids, funnel-shaped larynx. It may be a result of subglottic stenosis. The larynx is more superior between C2 and C3 versus C4 and C5 in the adults, and it's more anterior. The vocal cords are slanted posteriorly and superiorly. The influence of edema on tracheal diameter and airway resistance was described in the previous slides. Medical history, with its respiratory considerations, is very important as one gets ready to sedate children. For example, patients who have allergies or asthma or cystic fibrosis, and cystic fibrosis obviously has a great deal of highly mucus secretions. It narrows the airway, and asthmatics have this chronic inflammation which also narrows the airway, and allergies, which can be triggered by home environment or environmental considerations, also narrows the airway. So these three conditions make respiratory considerations much more difficult. Patients who have frequent upper respiratory infections also narrow the airway and compromises the volume of air that's able to be exchanged. Patients who have enlarged tonsils or adenoids make breathing more difficult because of the obstructive nature of these tissues, and because of that, it's more difficult for the patient to receive the adequate volume of air that's necessary to make them feel comfortable. And often patients who have asthma or enlarged tonsils and adenoids feel uncomfortable when these limitations begin to become even more severe. Tracheal defects such as tracheal stenosis need to be determined. Listening to the airway and if any noises that occur with that, there'll be a difference in sound of the airway and the exchange of air that occurs. Children that are obese will have a more difficult time because as they lay back in the dental chair, it becomes obvious that the weight of the abdomen presses on the diaphragm, makes it much more difficult for those dynamics of providing sufficient air to feel comfortable. Prematurity and low birth weight children often have a very difficult airway. They're presenting. Preemies up to 6 years of age may have residual pulmonary disease, and it makes it more difficult for this airway system. So those children who are premature need to take this into consideration in your physical evaluation of the patient. Listen carefully to the lungs and see if they have any things such as bronchopulmonary dysplasia, diaphragmatic hernia, or hyaline membrane disease, which it makes it more difficult for the airway to have the volume needed to exchange air for good respiration. The physiology of the respiratory system indicates that this is how you see the oral cavity and the pharynx, the larynx, the left main stem bronchus and the right main stem bronchus, and the lungs, which develop fully in children by age 8 and achieve greater levels of independence with their airway system and are much more likely to be successfully intubated. The physiology of the respiratory system involves inhalation and exhalation are the pulmonary ventilation. When air goes from the mouth through the nose down into the lung field, it gets to the lungs, and then the lungs accept the new oxygen, which is carried down by the hemoglobin, and exchange the carbon dioxide in the lung fields with the hemoglobin, and the CO2 is taken back to the lungs where it's squeezed out in through the nose and allows ventilation to take place. The carbon dioxide is carried by the hemoglobin back to the lung field where a hydrogen ion is removed and the bicarbonate carbon dioxide is removed through the lung field. The inhalation and exhalation are the pulmonary ventilation. The external respiratory exchange of gases between the lungs and the bloodstream, and the internal respiration exchanges gases between the bloodstream and the body tissues. Air vibrating the vocal cords creates sound. The more tense the vocal cords, the more rapid vibrations and the higher pitched sounds, the lesser tension and the lower pitched sound. And finally, the other physiologic aspect of the respiratory system is olfaction or smelling, and it's a chemical reaction at a molecular level, as seen in the illustration here on the right, that those molecules affect the chemical sensation, and therefore the olfaction or smelling of molecules determines what the odor might be. The children's airway physiologic characteristics include immaturity of the respiratory control and certain protective reflexes in the youngest of children, the size and collapsibility of the upper and lower airways, the lower efficiency of the respiratory musculature, and the reduced surface area available for gas exchange and altered balance of chest wall versus lung compliance. As the child continues to develop and improvements in the size of the exchange system occurs, it's easier for children to get their breath. But in the meantime, the children have lowered residual volume and can become hypoxic quite easily. The ventilatory drive in children is handled centrally by an autonomous ventilation driven by the partial pressure of carbon dioxide and the pH of the arterial blood and cerebrospinal fluid, and to a lesser extent by the arterial partial pressure of oxygen. So although we know oxygen is very important, carbon dioxide is equally as important because that handles the respiratory drive in the central brain. The ventilatory response to hypoxia is dependent on the CO2 level and is typically biphasic. After an initial increase in ventilation, sustained hypoxia reduces ventilatory drive. Compared to adults, children have smaller airways, and when sedated are more prone to collapse due to the lack of maturity of development, which strengthens the airway as development occurs. Due to the reflexive responses in healthy children, airway collapse is not observed. Upper airway patency is controlled by the CNS, the central nervous system, so any process affecting neuronal function, such as general or topical anesthesia, increases upper airway collapse. Children with obstructive sleep apnea have decreased neuromotor responses to negative pressures compared to healthy children. Because of reduced elastic pulmonary recoil forces, the lower airways collapse more easily, limiting early flow. Smooth muscle relaxation worsens airway obstruction in wheezy children. Inhalation of a beta-2 agonist aids expiratory flows in healthy children. The recoil of the chest cavity to inspiratory effort reduces functional residual capacity in children, 15% as compared to the 30% in adults. Patients with neurologic disorders, those that have seizures, have increased drug metabolism and competition for protein binding sites. Local anesthetics and narcotic sedatives have an impact on the seizure threshold. Children that have cerebral palsy are difficult to assess sedation depth, and it's really important for us to listen carefully, perhaps get an evaluation by the patient's primary care physician to see how severe the cerebral palsy is. Often kids can have the ability to communicate very well, and then some can't. So if we determine exactly how they do when they're sedated, it's going to be important for us to communicate that with the physician. If they have psychiatric or behavioral problems, ADHD for example, autism, there may be some drug interactions which occur with the medications they take to be helped. Emotionally unstable or effect on the limbic system. ADHD patients take a medication which dries out the mouth, and when it dries out the mouth, it makes it very difficult for them to control caries. And it's important that the parents and the child know that it's important to keep their mouth well hydrated if they're taking this ADHD medication. And ADHD medication may also work against the sedation drugs when they come in, and so it's important to suspend the utilization of those drugs if necessary, if there's any conflict with the sedation that's going on and the ability to take their medication. Oftentimes, ADHD children go on a drug holiday during the summer when school is out, when the physicians take that opportunity to make an adjustment in the dosage. As the child continues to grow and increase in size, it may be necessary to have an increase in the dosage. And during the summer is the time when kids are not in the school system and have that opportunity with their physician to adjust that dosage. Children with autism has different levels of autistic spectrum, and as these children receive drugs to treat their conditions, they also may have opportunities for drug adjustment, and it's important for us to understand if they're going through one of those adjustment periods, they may be increasing the amount of medication that they take, and it may affect the sedation episodes. Drug interactions between the drugs that these children take, asthmatics as well as ADHD and autism, allows the drug interaction with the sedation drugs, and it's important to make sure that if there are any drug interactions that we know about it, make adjustments for it, and alter the drug level as necessary. Children with these disease conditions often are emotionally unstable because of the threat of their disease waxing and waning with the medications that they take, and they feel very uncomfortable with the medications that they take, and it makes them not stabilized, and they don't know exactly emotionally how they're going to feel. And that has an effect on the limbic system, the emotional center of the brain. And when it does that, you may have a child come in that is going through an alteration in their drug regimen, and it may make them much more emotional than what was normally expected. GERD is another disease that may cause some difficulties in sedation, because GERD may cause enamel erosion, and it causes an increase in the treatment needs of the patient, but also that their stomach may not tolerate drugs that they take. And the important thing is that kids that have GERD, you see enamel erosion, it's important to work with a physician so that they understand that it may cause some difficulties with the patient when they come in for treatment. Vomiting may cause enamel erosion with GERD in children who have high gag reflexes, and this sensitive gag reflex may cause difficult erosive issues with their treatment. And if they're using drugs to control that vomiting, then it may be disadvantageous for the patients who are receiving sedation. Dysphagia or uncoordinated swallowing is something that needs to be carefully monitored depending upon what medications that the child is receiving. If they have difficulty with swallowing and dysphagia, kids often have a lot of plaque buildup on their teeth, but when you're treating them, the difficulty in utilizing water spray during those episodes makes it difficult to treat those children, and oftentimes consider sedation with those children, but you're adding another item to their management, and the management means you're going to give them sedative drugs and they're taking drugs to control their dysphagia, then it's going to be very difficult to treat these patients. Oftentimes these patients are better handled by taking them to the hospital. And kids with GI motility disorders, it's very important that we are aware of those conditions so that we can move those children into the hospital setting where it be more appropriate. The results in unpredictable bioavailability of oral agents and increased aspiration risk makes these patients high risk, and it's important to understand where they are so that we can treat them appropriately. These are examples of damage to teeth from GERD and GI disorders where nausea and vomiting occurs. This is chemical erosion on the left tooth surface, and it leaves these pits that, although smooth and oftentimes not symptomatic, but nevertheless are progressing towards the pulp. The teeth on the right-hand side, it appears as though they are hypocalcified and has some incipient carious lesions that will continue to progress if the child has condition where there's a lot of nausea and vomiting that occurs. It's also a sign for maybe teenagers who are undergoing anorexia and they're causing themselves to vomit frequently. You'll see this kind of condition on their teeth with lots of tooth decay. So it's important to find out these issues as you're going through your medical history with the child. Patient history and evaluation. Patients with renal and hepatic disorders. Weight loss is a common symptom in developing children because the hepatic disorders and renal disorders are reflected in medications that you may use. It leaves unpredictable drug elimination due to poor metabolism, results in increased plasma concentration of a sedative agent, and consultation with a nephrologist or gastroenterologist outlining clearly what sort of medication that you want to use and want to avoid over-sedation in these patients. So it's important to talk with their physician to keep this under control. Problematic sedation history. When we evaluate the medical dental history of the patient, we find out, have there been sedation failures? Have there been over-sedated? Were there periods of apnea? Were the sedations successful or were they failing? If they failed, what caused them to fail? Were there apneic episodes? Were there long periods of irregular breathing? Was the respiration rate and the depth of the respiration suitable for these children? And if not, then it may result in some oversedations that they have apneic episodes. For example, a case that I treated years ago, a patient came in, there was no history related to sleep apnea, and when we sedated the child, we laid the chair back, and when we laid the chair back, the patient stopped breathing, so we would sit them up, and the patient would breathe just fine sitting up, and then we put them back down, and then the patient became apneic again. So after a 2-hour time frame when a forced jaw thrust was used to help the patient recover, the parent was questioned again, and she said, "Oh yes, I forgot to let you know that the patient is snoring and has sleep apnea episodes." It would have saved the mom and the child a lot of difficulty to do that. The other thing is a paradoxical reaction. Now, a paradoxical reaction when you use a drug is that instead of sedating the child, it makes them hyperexcited, and it can last for a period of time, and nothing that you do can console them. And it's important at the time that you're working with this child that you can control their emotions, because this will have an effect on their expectation of treatment at the next time frame. And so paradoxical reactions, the parent needs to be informed that that sometimes happens idiosyncratically with a child, and it's important for us to know or that we have informed the parents that that may happen. General anesthetic reactions or complications that might have happened when a patient was previously taken to the hospital, let's say when they had their tonsils out or they had ear tubes placed. What sort of reactions did they have? Was it something that was involving the general anesthetic? If so, did they have any allergies to any medications? Did they stop breathing for a period of time? What was really going on during those time frames? Did they have previous hospitalizations with anesthesia complications? Perhaps they went in to have their appendix removed. Perhaps they went in to have a surgery for cleft lip and palate. What were the complications? What was going on at that time? And oftentimes the parents know some of the history, but not all of the history, and it's important to contact the hospital, get the hospitalization records, and see what went on in that history of the patient with their anesthesia to determine exactly what went on. Paradoxical reaction. In a document by Moon in 2013, paradoxical reactions were described to midazolam. The reaction mostly manifests itself after a period of short sedation. Within 5 minutes of sedation administered by IV, the child suddenly becomes aroused and cries in a state of intense agitation. And remember, this is a short period, because midazolam has a very short duration, within 5 minutes of sedation, and they start becoming highly aroused and begin to cry. Some children react by not recognizing their parents and becoming uncontrollably agitated. The exact mechanism is unknown, however. The inhibitory action of benzodiazepine may cause loss of restraint and cortical control. So children who have been accustomed to handling their own behavior, now they have complete loss of restraint and cortical control, leading to excitement to the point of hysteria nearly. In addition, benzodiazepines reduce serotonin neurotransmission, which may cause aggressive behavior. And the children with taking midazolam, that's sort of a common recurrent theme with postoperative nurses, that children that have taken midazolam tend to be aggressive to the point of belligerent. 4 groups of children were examined in this study by Moon, age 1 to 3 and 3 to 5. Groups 1 to 3 received doses of 0.5 milligrams per kilo and 0.1 milligrams per kilo, and age 3 to 5 received 0.5 milligrams per kilogram and 0.10 milligrams per kilogram. The incidence of paradoxical reactions was related to younger age and higher dose of midazolam, and treatment used was 0.1 milligrams per kilogram of flumazenil. However, caution must be used if the patient has any history of cardiac arrhythmias or seizures with benzodiazepine, because this will eliminate some of the treatment for the benzos. Patients with bronchopulmonary dysplasia are low birth weight babies. So the key is that you have a low birth weight baby. And when this patient comes in, you need to ask about bronchopulmonary dysplasia. Most outgrow it, but it can be fatal. It's the 3rd most common illness after asthma and cystic fibrosis. And then children with diaphragmatic hernias, a portion of the diaphragm herniates into the pleural cavity, and they lack the surfactant that allows bronchioles to expand, resulting in collapse during exhalation for the kids with hyaline membrane disease. So those 2 conditions, bronchopulmonary dysplasia from low birth weight patients and babies, they must outgrow, and then diaphragmatic hernia is an important one to see because it interferes with the proper motions and function of the diaphragm. Asthma sedation indications. Children often are overindulged due to their asthma. They have a poor oral hygiene and diet. They require management to reduce stress and anxiety. Reduces induction. Present with higher caries rate due to beta agonist use with decreased salivary flow by 35%, increasing the lactobacilli with a low pH. So patients who are on these beta agonists, it decreases the salivary flow, and these patients should be rinsing with water after their use of their medication to decrease the effect on the dentition. Asthma attack. How to prevent an attack? First of all, prevention drugs are used. An inhaled steroid like albuterol or triamcinolone, Asmacort, or inhaled long-acting beta agonists like solmeterol and Ceravent. If an attack occurs, how you treat it is to management of the drugs used. Use a metered dose beta agonist inhaler, which is albuterol, Ventolin, or liquid nebulization, metoprolol, Alupent can be used with a spacer to use in your treatment of these patients. What is the frequency of the attacks? And remember, we talked about the persistent versus intermittent attacks and the mild, moderate, severe, asthmatics and determining which ones. So looking at their medications that they take will help you to determine exactly the nature of the asthma that's going on. And recent hospitalizations, were they hospitalized because of the asthma or for some other reasons, and how was it handled? Were there any apneic episodes when they were in the hospital? Mild to moderate asthma, you have preparation when using PRN inhaled beta agonists. There's a daily administration for 3 to 5 days prior. They have an inhaled steroid, the triamcinolone Asmacort, or an inhaled beta agonist, salmeterol or Ceravent. Remind the patient to bring their bronchodilator, an inhaler, to the appointment. Update the current history, and perform a thorough auscultation of the lungs, listening for any sounds that may occur. And when you do the auscultation for the lungs, you also listen to the heart, listening for any sounds. And again, when you're listening, we'll be talking about the utilization of the stethoscope later on how to appropriately hear the correct sounds. But it's important for you to know that auscultation of the lungs and the cardiovascular system is important before you do sedations with children. Defer the sedation for 4 to 6 weeks in the presence of coughing, a recent URI, or a ER admission. Asthma pre-op preparations. If you're using chronic oral or inhaled meds, you need a consultation about the addition of oral steroids. If you're considering a general anesthesia rather than oral sedation, recent hospitalization within 6 weeks of treatment date precludes elective procedures. Reschedule this patient. Wait 6 weeks for the lungs to heal up and to function again properly. And if that doesn't happen, then you may have to delay treatment of these patients. We've had patients that come in with a chronic asthma condition, and it was hard to find a time when they didn't have the sniffles or have some kind of secretory result from having the asthma. Does the patient have a URI? Postpone elective treatment for 6 weeks in the presence of coughing, even if there's no wheezing, and you should be able to hear that high whistling sound with wheezing that comes along, because there is an 11-fold increase in respiratory complications. Now, what is the sedation protocol? You want to avoid known precipitating triggers or factors, and it's important to question very carefully the parents on what they think are the triggers. Often parents know, mothers know, what will trigger an episode, and they try to keep that from happening. There are seasons like hay fever season that comes along, or early in the spring when lawns begin to be mowed again, that these can precipitate some asthmatic reactions on these kids who are susceptible to that. And you need to know when they're coming and make sure that they have had a period of time when there's been no significant asthmatic conditions arise. The use of nitrous oxide oxygen inhalation. After all, because we never use less than 30% oxygen, we are supplementing them with oxygen, and it's been speculated that the taste, the smell of the nitrous oxide stimulates the child to have an attack, but it's been found that it's quite safe to use nitrous oxide oxygen with a controlled asthmatic and do that successfully, and in fact maybe assisting the patient with additional oxygen. Local anesthesia has an individual action of its own, and local anesthesia with vasoconstrictor precaution, because the local anesthetic contains a bisulfate preservative, and we need to watch and make sure that patients that we treat don't have an allergy to any sulfur drugs. And if they do, then we need to find a medication that we can use that will be without this bisulfite preservative. We may add to the cardiovascular effects of beta-2 agonists, resulting in palpitations, increased blood pressure, and arrhythmias. So the utilization of local anesthetic needs to be handled and ensure that we aspirate beforehand. Consider the use of 3% plain local anesthetic solution. This will allow us to not have to deliver the epinephrine, which, if inadvertently placed into the bloodstream, can cause a problem for the child. The addition to avoid narcotics, which influence histamine release in a patient who has asthma. If we have a concomitant condition of mast cell release when a narcotic is used, Demerol, for example, try not to use those with patients who have asthma or seizures because of the possibility of mast cell release and the initiation of a seizure episode, and aspirin-containing medications also for similar reasons. Avoid deep sedation. The airway is more reactive, has a higher risk of laryngospasm and bronchospasm. It's important to know when to diagnose that, and we'll be talking about that later. Minimize water spray irritation on the airway, and use minimal sedation with midazolam. Now, what are some of the acute asthmatic attack symptoms? Well, there's respiratory and behavioral. The respiratory is coughing. If you have a child that has a consistent cough, then they may have a mild to moderate case of asthma. Or are they short of breath, particularly in the seasons when we know that hay fever occurs? Do they have a bronchospasm where wheezing is detected? Or a tachypnea, which is a rapid breathing? Do they have any nasal flaring where they're having difficulty getting breaths in? And other chest muscle retractions where the chest is tightening and we see those accessory muscles in the chest are being utilized because the patient is short of breath and the patient is breathing rapidly. So it's important for us to recognize those respiratory symptoms. Behaviorally, the patient sits up in the chair, they have increased anxiety, there's a lot of agitation going on, and a lot of confusion with the patient once they start having an asthma attack. Management of escalating conditions, and it's important to distinguish, is the child having an allergic reaction or are they having an asthmatic attack? And often the initial symptoms are much the same. The important thing is when you have a patient bring their inhaler, they can use that inhaler, and if the patient is not getting better and they have dermatologic symptoms as well, for example, if a rash begins to develop or they have an angionotic edema occurring, and it's important for us to be considering the utilization of epinephrine instead of the albuterol inhaler. So you take the albuterol inhaler and they take 2 or 3 puffs every 2 minutes, or twice a time every 2 minutes, 2 puffs, or a nebulizer treatment. And a nebulizer treatment is something, if they brought a nebulizer with them, some children carry that, and use oxygen at 5 to 8 liters per minute via a non-rebreathing face mask. Obtain the vital signs, the blood pressure, the respiratory rate, the heart rate, the hemoglobin oxygen saturation. If they exhibit dermatologic symptoms as well as the difficulty in breathing, then you might want to consider using a rescue 0.15 milligrams IM or submucosal every 15 minutes PRN, or combating the anaphylactic reaction of the patient. Diphenhydramine 25 milligrams IM or SM stat, then PO Benadryl TID times 2 days, or a medical referral after calling EMS. Allergic rhinitis versus upper respiratory infection. Allergic rhinitis, usually you see clear rhinorrhea, which is nasal discharge. And if the patient has that, it's been sneezing, has a little red-rimmed eye with conjunctivitis and nasal itching, then it's more likely to be allergic rhinitis. And for those patients, we can give them antihistamines for their itching and leukotriene modifiers, which will help with that. If the patient, however, has a URI, the rhinorrhea has a yellow or greenish component to it, and the nasal passages are often obstructed, and they have a fever or cough. And if they exhibit those symptoms, it is time to reschedule a patient, even though they might have come from a long distance, and prescribe some decongestants or get them to go to their physician to prescribe some decongestants, some anticholinergics, and circlesonide, which is a new drug to use with the upper respiratory infection. Upper respiratory sedation precautions. The patient has an irritable airway prone to coughing, breath holding, and laryngospasm. If the child has active URI, cancel sedation and wait at least 2 weeks to reschedule. Allergic rhinitis may never completely clear, and decision or sedation may cautiously be made. If the patient is exhibiting continuous allergic rhinitis, there may never be a period when this child does not have that complication. And so if you plan to sedate that child or give them some nitrous oxide, you will best let the parent know that you'd be willing to do this, provided the patient has clear secretions that are coming out and that they don't have a continuous cough when that happens. And just lightly sedate the patient as light as possible. In general, the dental team infection irritates the airway, smooth muscle constricts, and the presence of a cough, nasal passages are not patent. There's no nitrous oxide or rubber dental dam use, post-nasal drip, airway irritation. So as you evaluate the child, is there, and I've alluded to this earlier with a case description, is there a history of sleep apnea? You really want to know that. You don't want to be in the position of finding out that they have a history of sleep apnea. What exactly is sleep apnea? It means when the patient has an obstruction and for a period greater than 10 seconds that the patient is not breathing, and then they kind of go through this inhaling a series of short breaths to get some oxygen back into their system. And if they do that, it's quite apparent that this child does this overnight. It would be something that you'd consider that perhaps they should have a sleep study done to see if the patient has sleep apnea. Secondly, does the child snore? And oftentimes when you see enlarged tonsils, the children will be snoring, particularly with a child who tends to be on the heavy side. Do they have difficulty sleeping? If they have difficulty sleeping, what we often hear once the tonsils have been removed is that the patient's grades improve in school, they sleep better, they play better, they're much more amenable to being social. And so difficulty sleeping is something to determine by asking the right questions. Does the patient have enlarged tonsils? Is the patient lethargic? Do they have difficulty staying awake during the day? Are they mouth breathing? Are they obese? And that means greater than the 95th percentile for these children. So if they have any or all of these symptoms or some, it's important to determine for yourself, where do you want this child to go? Do you want to do some sedation, or do you want to be able to take this child to the hospital where it's much safer? If intubation needs to occur, somebody is well trained to be able to do that for you. Down syndrome, trisomy 21, occasionally have airway obstruction, and they do that because they have relative tongue obstruction, a macroglossia, and sometimes they have a malocclusion. So with these factors combined, what you want to look for is that they have a large tongue and small nares. Do they have sleep apnea? Because 30% of them do. Do they have frequent URIs and immunities to URIs, or are they pretty prone to having URIs? Do they have any cardiac defects? Many children that have trisomy 21 do have cardiac defects. They have a heart murmur. Either it's a significant heart murmur and they're premedicated for it, or they don't. Do they have subglottic stenosis, which means just below the vocal cords is some narrowing of the trachea, and that may result in some difficulty in getting air exchange. If so, you have subglottic stenosis. You want to know that in advance, because if you had a condition arise in the office where you wouldn't be able to do some intubation, it could be life-threatening. Whereas if you took them to the hospital, you have an expert in intubation up there to help you. Or tracheal stenosis as well, which narrows the airway, and we know that to start off with, it narrows, you have a very narrowed airway, and they have a short, thick neck, which is difficult to pull the tongue aside and to lift anteriorly and superiorly with your laryngoscope to be able to remove the tongue and get to the vocal cords to intubate. And finally is atlantoaxial dislocation from the neck flexion. 10 to 20% of trisomy 21 children have these, and if they have this difficulty, you have to be very cautious that you don't dislocate the atlantoaxial anatomy, and which will not occur adequate neck flexion. If you have the normal 4 millimeters that they request, if they have greater than the patient we saw before with 11 millimeters, it means it's highly flexible. And if you have to hyperextend the neck on this patient, you may have a dislocation and you can paralyze the child. So this is very important with trisomy 21 patients. It may be best to refer them to the hospital and to be wary if they've already had a diagnosis of atlantoaxial dislocation. They often have radiographs taken to determine if that is a condition that they have. Obesity occurs in 17% of the patient. It's tripled in the past 20 years, and it's defined by percentiles. If it's greater than the 95th percentile, they're obese. It's greater than 85 percentile, but not 90%, then it's overweight. So an adult with a BMI of greater than 30, a child with a BMI varies by age and gender. Important to find out, and here's the nomogram we talked about, which allows you to put the body mass index for age from 2 to 20 years of age, and it shows some examples of children who've been put in a special category, but when they get above the 95th percentile, they are obese. I've treated a 60-pound 4-year-old with some care and concern because of the obesity that occurred with this child. You just don't want to put yourself at risk or the child at risk when you're doing these patients. Obesity is internal and external airway compression from fat deposition, increased airway resistance, takes a greater pressure to get the air through the compromised airways of the patient, and whether they're being compliant and have, you're going to be able to do some neck flexion with these patients, because when you start tipping the neck up, it's really the unsupported portions of the airway and the soft palate and the larynx that is of concern, because it collapses and not supported by cartilage. The most difficult airway to maintain patent. It's prone to developmental obstructive sleep apnea in 5%, and it has frequent FRC and become hypoxic, functional residual capacity, reduced frequent functional residual capacity, and they become hypoxic very much faster. And you see in the lower right-hand corner a picture of the oxygen hemoglobin desaturation curve, and down on the bottom it has the percentage, it has the age of the patient, and or the number of percentage of patients. Down on the bottom you have a picture of the oxygen hemoglobin desaturation curve, and it tells you what can happen once the oxygen carrying capacity of the hemoglobin decreases, how quickly the patients can desaturate. An evaluation of this patient's medical and dental history requires a review of systems to ensure the integrity of the child for cardiovascular, respiratory, liver, kidney, allergies, medical conditions that may reduce the ability of the child to tolerate sedation or hospitalization, obesity, limited neck mobility, retrognathia, microglossia, The Mallampati score is important to do, and that's the score that you get when you test the patient for the amount of space available between the posterior soft palate and the top of the tongue. When the uvula disappears from the patient's mouth visually, and you have limited oral opening, it's important to know that in advance, because you need to ask yourself, if push came to shove, would you be able to intubate this child? And if you have a high Mallampati score and you're not able to do that, you've discarded your caution and have a high-risk situation about to start. Cardiovascularly, you check the blood pressure and the pulse. A rule of thumb that we learn in PALS is that the systolic blood pressure is the age plus 2 times the age in years. And when you know that from the systolic, that the diastolic is usually 2/3 of the systolic, then you can calculate that blood pressure is an appropriate one for that age child. If it's high, you need to have an investigation as to the hypertension that's going on, and maybe make a referral for evaluation of the cardiovascular system. And are they taking any high blood pressure medication? Remember to take it twice if it's done electronically. If you do it physically, you may want to take it a couple of times with your blood pressure machine, and then take it one time manually with your instrument to be able to determine the blood pressure. Respiratory, you want to know, does the patient have asthma? What score of Mallampati if they've been diagnosed? 1, 2, 3, or 4. Remember, 1 is the least and that 4 is the greatest. So those are the things you want to look for. Look for allergies. Did they have any drug allergies? Do they have any food allergies? Do they have any contact allergies? And that's the triumvirate that if they have those, it's very easy for them to have asthma as well because of their limited IgE functions, and should put you on alert that allergies may cause you some difficulty. Is the renal function okay? Is the kidneys okay? Will it be able to handle? Some patients these days have renal failure and are on the waiting list and have severe dental problems, and you need to interact with a physician to be able to know when to handle those renal patients if they have end-stage renal disease. Hepatic function, make sure that the liver is working appropriately, because the first pass of many of our drugs goes through the liver, and some of it is filtered out at that time, and it's important for us to know, do we have a properly functioning hepatic system that allows us to give drugs of sedation to our patients. And finally, obstructive sleep apnea, and that repeated episodes of desaturation. They may have altered mu receptors and be analgesic at opioid levels 1/3 to 1/2 those of a child without obstructive sleep apnea. Lowered titrated doses of opioids should be used in this population. This is important to know, that if a child has obstructive sleep apnea, then they may be taking some medications that are utilized regularly on the mu receptors in the GABA system, and if so, they may be sensitized to these drugs, and if so, and you add a sedative drug in the normal ranges that you normally employ, then you may overdose these patients, because 1/3 to 1/2 of those children, without sleep apnea, do much better than those who have been exposed to multiple episodes of their analgesia. Lowered titrated doses of opioids should be used in this population, so watch for that carefully. Cardiovascularly, a thorough focused evaluation of the family and parents' cardiovascular or patients' cardiovascular history is essential to rule out any abnormalities. Is there any history relating to restrictions of physical activities? In kids that are restricted in activities, you need to find out the reason. If it happens to be cardiovascularly related, then this is not a patient that you'd want to do treatments of sedation in your office. Does the patient feel unusually tired after sports or strenuous activities or climbing stairs? If this is what happens with your children, they may have a compromised cardiovascular system. Does the patient feel out of breath during exertion or have to take a break to catch their breath? And these are important questions to ask when you're doing a focused evaluation of the cardiovascular history. Because if they have any of these, they have a difficult time in being able to maintain their respirations due to the exertion it places on their heart muscle and the pumping ability of that heart. So find those things out before you get started. Is there any sign of a heart murmur mentioned by your pediatrician? There are innocent murmurs with children in the early stages of infancy that are ones they'll grow out of as time goes on, and maybe holes in their heart that will decrease in size or become innocent. So the key word is innocent. Is this an innocent heart murmur? If it is, then you can feel very comfortable, and make sure that you have this well documented in your literature, in your documentation, so that you will know the child's history has been clearly disclosed to you. Does the child feel any extra beats at any time? Some premature atrial contractions can occur in some kids, and it means that there's a little problem in the timing system of the heart. And if they have these extra timing things, there may be some catch-up beats, and one should be able to hear that. So asking the child, do they feel any palpitations at any time when they get nervous? Is there something like that going on? Has the child ever had a special heart x-ray by the physician? And if so, then it's important to make sure the child has been carefully evaluated by pediatric cardiology before you consider sedation. Are there any anomalies detected by your pediatrician? Has your pediatrician told you to avoid dental treatment unless you have antibiotics? Have they talked about a heart murmur, and was it innocent or not? Do they have ADHD? Do they have any liver, kidney, lung problems? If so, it's important for that to find out. And sending a quick consultation if the parent doesn't know to the physician, saying that you want to do some sedation and you're going to use these drugs dosage, and this is what the drug dosages will be. Make sure that you clear that with the physician before you go on. And then history of cardiovascular disease in the family. Is it on the mother's side? Is it on the father's side? Was anybody hospitalized or have a disease condition or death before the age of 60 in the family? And if so, then you might want to find out about grandfather, grandmother, what kind of conditions that they had. What is the cardiovascular health? It's best evaluated by pediatric cardiologists who treat many children for congenital heart disease and perform invasive procedures to improve the health of these children. The variable cyanotic and non-cyanotic heart conditions should be evaluated by our cardiac colleagues to ensure safety or precautions for sedations. And mentioning the cyanotic heart defects, these kids will have really kind of bulbous fingers that are cyanotic. When you look at the tips of their fingers and underneath their fingernails, their condition looks like they're kind of purplish in color. And the kids are usually have a cardiac condition that requires careful evaluations and treatment. So if you have any questions about these conditions, it's important that you email us at the PACE Center at uth.tmc.edu. We'll be happy to correspond with you and let you know anything that we can clarify for you. Listing of the references you will see. This is all the background information that has been provided for you to utilize and to investigate and to learn more about what you're doing. And it's a way for you to ensure that your skills and your didactic knowledge and scientific information is complete so that you can handle these patients safely and that your outcomes are very favorable. This completes this section of the course. It is time for you to take a short exam in order to complete the requirements for streaming video courses. Due to the nature of our subject content, a passing score of 80% is necessary in order for you to advance to the next section. Upon successful completion of this exam, you will be visually informed that you have met the requirements to proceed. If you fail to answer enough questions correctly, you'll be instructed to take the exam and a new set of questions will be provided. You will have 3 chances to fulfill the requirements. If you are not successful, you will be instructed to review this section again. Good luck on the exam. If you're ready to take the next section, upon completion of this exam, you will be provided a link to continue. If you wish to proceed at a later date, you will need to log in, and no further payment is necessary since this is a continuum.